Okay, so talking about perfusion, obviously our baseline assessment is going to give us a lot of information. So general appearance, how would somebody that is having issues with perfusion appear?
Cool and clammy.
Yes, they might be cool and clammy, typically pale, sometimes a little tachypnic because that's our compensatory mechanism, a delayed capillary refill or sluggish capillary refill. Vital signs are typically inversely related. So we have, hypotension and tachycardia associated with that. Peripheral pulses might be like a 1+, kind of weak, thready. And then obviously with our urine output, so urine output, I just want to mention, because this goes into the shocks as well. If you have got increased urine output and it's 30 or greater, their fluid volume status is improving. Okay, so that's kind of just like a general rule. So I know we talk about like daily weights, same time in the morning, same clothes, same bed, but really your best indicator of is your patient getting perfused is going to be that fluid out. It's going to be that urine output. Okay, so oftentimes in ICU, you'll see the Foley catheter that has the urometer attached to it. And if it's ordered for them to have hourly urine outputs, like it would be, what device do you think would have an hourly urine output requirement out of the 4 that we talked about? You have a 25% chance of getting it right.
The IABP?
The IABP, yeah, the intra-aortic balloon pump, because that with its position and how it's blocking some of the circulation to the body by keeping it in the heart. So that would be decreasing your urine output. So every hour you could go in there and you can dump that urometer into the bag and get that accurate urine output. Okay. Rob, when you turn this one in, I just want to say you got 7 wrong on this one. Yeah, I know you tried hard. Like, next time you look at a tiger's a tiger,
Damn it, I knew it. I asked like 4 people.
They set you up to fail. They're not your friend. So systemic and pulmonary arterial pressure. So central venous pressure, that right end diastolic function. So it's a little bit less indicative than your pulmonary artery catheter, because with their central venous pressure, it can be elevated in patients with heart failure, but really that CVP is going to be elevated in what types of situations?
Hypervolemia.
Yeah, so like fluid volume overload, and then it would be decreased in fluid volume deficit. So when I say I don't want you to focus on the numbers, because parameters are going to vary, with each individual. They're going to have set guidelines with what we want to keep them at, but just kind of keep that in mind with the central venous pressure, that if somebody is having issues with fluid volume overload and we see their pressures are going up, that would be a bad sign. That would be like, okay, like their heart is still really struggling to compensate and maybe kind of slightly giving up in that, if those pressures are going up. Pulmonary artery wedge pressure, obviously we talked about, does do a lot of things. However, kind of the same premise. If it's high, fluid volume overload; if it's low, fluid volume deficit. And this will take into account heart function. So we can actually correct fluid imbalances much better with a pulmonary artery catheter. But you don't see them has anyone seen one in clinical? Nah. Yeah, you might not. I mean, the risks of putting one in sometimes outweigh the benefits of having it. Or what I've seen as patients are, they're too sick that they start having the conversations of, like more ethical, what are we going to do with this patient? And then cardiac output, How do we calculate cardiac output?
Stroke volume times heart rate.
Stroke volume times heart rate. Okay. Get that. You guys did your matching worksheet, so make sure you look that over. Don't worry about these guys. These medications are on your drop down. Let's review. What's norepinephrine for?
It's a vasoconstrictor.
So how does the body respond from that?
Increased blood pressure, increased systemic vascular resistance.
Yeah, so it increases the blood pressure. It kind of tightens everything up to maintain that blood pressure. Very, very commonly used to with patients that are hypotensive. Usually the parameters are to keep that mean arterial pressure above greater than 65. And it's really helpful when patients are intubated and sedated because propofol will sometimes have the effect of causing hypotension. So norepinephrine will kind of, keep things going. However, it does run the risk of when it pulls the circulation from the extremities, you get the cyanosis in the periphery, like the fingers and the toes, and prolonged, lack of blood, lack of oxygen. But it's rare complication.
I have a question about that. We have a doctor that I work with who coded like 3 or 4 times or something, and I got a different hospital. And he came back and he's still working. Like he works with us now. He's a really nice guy. But after that happened to him, I think he had like toes amputated, or he walks with a limp right now because somebody mentioned that he had decreased the extremities. Would that have been like, you think that would have been norepinephrine that did that, since he was intubated and his heart stopped?
Definitely prolonged period of time on that. And then the toes would definitely be the first one to suffer, since they're the most distal to the heart. So they're the ones getting the decreased circulation. So yeah, it can cause that. But again, risk versus benefits. If they need it to maintain that core circulation, we have lots of patients on it. Dobutamine.
Hypertension, tachyarrhythmias.
What is its mechanism of action? What is it doing? So we need to look over our drug drop down, right? We're going to look over our drug drop downs. Yeah.
Mm-hmm.
Do you guys see I'm wearing a comfy? Have you heard of this on Amazon? Like a giant sweater with like a hood, but it's like a blanket. You have not heard of the comfy? It's kind of like
Is it like a Snuggie, like one of those things they had on TV?
Yes, exactly.
A blanket that you wear, right?
Yeah, it's like the new thing. I can't believe you guys haven't invested in this. My husband was making fun of me. He's like, I can't believe you ordered that. And then last night he was wearing it. And I was like, get my hoodie off. And he's like, it's a blanket. I'm like, no. I'm like, that's a blanket sweatshirt. So like, it's mine. Like, it's my piece of clothing.
You said they're on Amazon?
Yeah, look up the comfy. They have all different colors. Get yourself a nice leopard print.
That is good to know.
So here is our pressure monitoring system. If you have a chance to see this in clinical, it's kind of neat to see the setup of it in the room. But I think you guys are pretty familiar with this. I saw your guys' discussion board posts. So where do we position the transducer?
Phlebostatic axis.
Yep, phlebostatic axis. Pressure bag is inflated to
300 millimeters of mercury. Is that what the measurement is?
Yep.
Okay.
And how fast is it pushing the fluid into the patient's line?
3 millimeters milliliters a minute,
3 milliliters
an hour.
hour. Yeah, so it's
Yeah.
just kind of slowly keeping it patent. So here we talk about our arterial line. So we have that 300 millimeters of mercury. When you do that fast flush, when you pull that little tab, let me go back. Ah, what's happening? Okay, looks like I'm going the wrong way. Am I going crazy? Oh, there we go. Okay, so you pull this little tab. You can't really see it too much on here, but it's like a little rubber tab. That will flush that solution in at 300 millimeters of mercury. So think about like if your blood pressure, if your systolic blood pressure was 300, right? You'd probably explode. What that's doing though is just kind of resetting the system, flushing that in at 300. And then once, you know, you do that quick little few second flush, when it comes back down, our goal is to pick back up the systolic and diastolic blood pressure and have it look more like this waveform. You could see that little notch in there. Okay, we talked about that. Zeroing, so open the system, make sure it's off to the patient because as we know with arterial line, it's going right into an artery, so risk for bleeding. So we got to make sure that we turn it off to the patient, open it to the environment. That sets that pressure at 0. Okay, mobilize. So high and low pressure alarms are going to be determined based on the patient. What do we see their blood pressure doing? What's their baseline? And then we can kind of go from there and put that high and low pressure alarm. And oftentimes when you get the high or low pressure alarm, it's because the system itself needs to be kind of reset and go through that fast flush. Should correlate with what 2 things? Your arterial blood pressure monitor. What 2 things do you think it should match up with?
The blood pressure.
Yep, the manual blood pressure cuff. So it should correlate with that. And then what's the other thing that we're monitoring on a patient that has a waveform?
Respirations.
Not respirations, although you
O2 saturation.
not O2 saturation.
The EKG.
Their EKG waveform. So hemorrhage, we know it's in an artery. If it comes out, low pressure alarm will go off, but your patient will keep bleeding from that artery until we're able to apply direct pressure. Pressure has to be applied for 5 minutes, manual, and then pressure dressing after the fact. Any invasive device, risk for infection. Thrombus formation, if there's platelets that aggregate around that catheter, if the flush solution isn't going through, they're at risk for forming a blood clot there. Neurovascular impairment, this is the only one for neurovascular just because of the location that it's in that wrist. There's bundles of nerves there. So they might have some residual from having an arterial line. They might have some residual like numbness or tingling in that extremity. Loss of limb, rare, but if it, they do develop an infection, could happen. Okay. We talked about that. We talked about what we should be assessing. Don't worry about that. Don't worry about this scary picture. Okay, so here we have it actually being inserted into the heart. So the balloon is inflated. This is where we're most concerned about what complication.
Arrhythmias.
Yeah, dysrhythmias, because it's functioning on an electrical system. So if it stimulates that wall, it gets on the patient into an abnormal rhythm. So this is the waveform you should see while it's being threaded through into the heart. Once it reaches that pulmonary artery, we see that wedge pressure on there. Wedge means that the balloon is inflated. The balloon is wedged in there. At that point, the catheter would be sutured in, and then that balloon would remain deflated until we're actually obtaining a wedge pressure. Okay. So how we do that, slowly inflate the balloon. How much do we inflate it with?
1.5 milliliters.
Yep, up to 1.5 milliliters of air, and then 8 to 15 seconds maximum time that we would inflate that balloon for until we just obtain our reading. And it should, again, if this is ordered every 4 hours, they should kind of correlate with what's going on with the patient. In terms of inflating that balloon with air, the reason why we want to slowly do it is what is a risk factor of quickly putting pressure into a line.
Pulmonary artery rupture.
Pulmonary artery rupture, we can damage those little small vasculature. We can also rupture that balloon, and then we're talking air embolus. So it's one of the reasons why your central line, the group that did that put the 10 cc flush on there, like periodically flush with 10 cc's. A 10 cc flush has a thicker circumference, right? It's a bigger circumference. So it's less pressure when you're pushing 10 cc's. A 3 ml syringe has a smaller circumference tube, so it's a higher pressure. So we always want to use 10 cc syringes when working with this equipment because we want to make sure that we're using a lower pressure syringe. Does that make sense? Okay, so we have this over wedged balloon, very, you can see that this tracing is very abnormal when looking at it. So at that point, we'd be concerned about maybe the catheter migrating, or, maybe having too much inflation of the air, and that balloon, expands too much. So definitely something that we would want to address if we have an over wedged balloon in there.
Well, I had a question about when that balloon is inflated as far as like during the cardiac cycle. Is it if the balloon would inflate during diastole and then would deflate during systole?
Well, we are actually doing the inflation with it, with the air. So we're doing it correlating with this EKG waveform. With the intra-aortic balloon pump, the machine does that automatically.
That's what I was talking about. Yep.
Yeah.
Okay.
And that is on a timed system. And during systole, it starts to, it's like that sausage shaped balloon. The machine starts to inflate that big balloon because what it's doing is basically during systole, your heart's pumping blood to the body. This balloon is keeping some of that blood flow back in the heart. I've seen the IABP used mostly for patients that are waiting to go for a bypass. Like they have like a 98% occluded, vessels. And this way we make sure we keep that blood going in that coronary.
Okay, yeah, because that IABP is mostly for getting blood back into, increasing pressure back into the coronary arteries for the heart.
Yeah, temporary circulatory assistance in the heart.
Okay, gotcha.
Did that person that did they have an IABP or no? Because that could also cause damage to the
I haven't heard anything about that. I'm gonna ask though. I go to work tomorrow. I'm gonna see what happened. He's like our director of the ED, so and he's really cool. I'll ask him.
Yeah, because that could also, especially used in conjunction with like a Levophed or something, could take blood flow. All right. Okay. Okay, so your tubing's changed every 4 days, every 96 hours. So the whole system, we'll do a whole new setup of system, just like you would with your IV tubing. So air embolus, we talked about monitoring for balloon integrity. If you see that waveform go flat, that would be a bad sign, like you're over wedged as the balloon is full. Under wedge, if you go to inflate the balloon and nothing's coming out on the waveform, issues with balloon integrity. Again, extremely, extremely rare, but something that we're monitoring for as nursing staff. Right, just So here's the ear embolus, here's centralized site infection. I would say infection's probably the biggest risk with your central lines, just because of the fact that they stay in the longest, and they typically have like fluids and solutions like TPN and stuff that like bacteria love to congregate in. But CLABSIs are considered never events. So really strict, sterile central line care, dressing changes weekly or as needed, and just like monitoring for any types of signs and symptoms that, the catheter has become infected. Okay, so circulatory assist device. So this is decreased cardiac work when drug therapy, is no longer adequate. This is most commonly used in patients with end-stage heart failure. Okay, so we talked about the IABP. We said temporary circulatory assist because we can't have this in for a prolonged period of time. That decision has to be made whether this patient's going to be a candidate for surgery. Because by having this in, not only like the level of the fact that the patient has to be like, almost supine up to 30 degrees, that leg has to be immobilized, they have to be log rolled, but also just the fact that it is taking circulation away from the body. Okay, so our risk factors for this, what do you guys remember? What are some complications?
Vascular injuries, thrombus formation,
Mhm.
thrombocytopenia infection.
Thrombocytopenia infection, and it is in an artery. So again, we do worry about bleeding with that, or hematoma formation if there's blood that leaks into the surrounding tissues.
So explain the thrombocytopenia again. I know, Leslie, you were telling me about it yesterday. I can't remember why it causes thrombocytopenia though.
Oh, do I explain it?
Just
I want to hear your explanation.
So my reasoning was that when it's inflated, it's causing pressure on the circulating cells. So since the platelets are so small and fragile, it causes thrombocytopenia.
So it lyses them that way, like it just literally physically destroys the cells from the pressure.
Also on insertion as well, from that catheter being threaded up, can cause thrombocytopenia. But think of it in terms of like that big long catheter, because think about how far away your heart is from that femoral artery. So if platelets are aggregating around that catheter, you're going to have less free platelets in the bloodstream. Does that make sense?
Mm-hmm.
And throm means platelet.
So these patients need to be on blood thinners, while
They will typically have, I've had some patients that have a heparin drip, but then other patients will just be on that standard heparin sub-Q. It just depends on the patient and what they have going on.
Okay, because it's a temporary. IABP isn't in forever and ever, right? So
yeah, a better medication, but again, this is temporary use. So by the time that medication will work, would be like a clopidogrel bisulfate, the Plavix, that inhibits platelet aggregation, but it's still not going to prevent the platelets from sticking to that catheter. Does that make sense? Okay. All right, so vascular injuries, thrombus and embolus formation. Leslie stated these out very well. Ischemia, we talked about, to periphery, kidneys, bowel. Those are periphery first, kidneys, and then the bowel comes after that. And that ischemia to periphery, kidneys, bowel is something that's going to continue on. We talked about how even mechanical ventilation causes that. And then all of your shocks, can sometimes cause that. Any type of perfusion issue would lead to that. And then infection, of course. All right, don't really have to worry about complications as much with the machine itself because of those fail-safe features. So the machine will automatically shut off if there is an issue. It won't keep, for example, it won't if there's that improper timing of the balloon where it's inflating and preventing all circulation going to the body. It's not just going to continuously do that. The machine will sense that and turn off. I've never had that happen before. They're pretty reliable machines. I should talk to Donna about getting one to show you guys. It's probably only about 200 grand. We could swing it, right? Okay. So here it says less than 40, your book says less than 45. Most hospital policies are less than 30. For the majority of the time, we have patients that are supine that have this, and then they're keeping their head in alignment. Okay, don't worry. Has anyone ever seen an LVAD? It's used more outpatient. Like if you go to like a heart clinic, you may have patients coming in for checkups with an LVAD, but no risk. Okay. You guys want to move on to, how do you feel about respiratory failure? Feeling pretty good? What are you struggling the most with now? Mechanical ventilation? Yeah.
Can we just talk about like the early signs of ARDS and then the later signs of ARDS?
Sure. Okay, so break this down. All of this scary terminology that you see on here is it's just fancy ways of saying what's happening in the lung itself. So our injury or exudative phase, so within that first week, now this can have like an abrupt, response from the patient, or it can be more like insidious in nature where they're just not really feeling good. They're feeling a little bit short of breath. The issue with that, if the patient has like a comorbid respiratory issue like COPD or emphysema, comes in like a later diagnosis of ARDS, and early intervention is key when we're talking about acute respiratory distress. Fortunately, a lot of the patients that are having complications from COVID are going into this, are going into ARDS from that. So 1 to 2 days. So when you think exudative, what does that word mean to you?
Fluid and inflammation.
Right, fluid and inflammation. So exudative means like a leaking of fluid. So you think like exudate from a wound. So here we have alveoli filled with fluid. The inflammation itself causes more fluid that brings the mast cells and mediators to the site, which actually does more damage, as we know, in the lungs. If those fluid-filled alveoli, then we have that VQ mismatch. And then additionally, there's decreased surfactant, which what does that seek to do, your surfactant in your lung tissue?
Keeps the alveoli from collapsing.
Yeah, it keeps them from collapsing. It kind of lubricates them too, so that when they have an easier time reopening as well. Okay, so we talked about the edema. So edema, atelectasis from the decreased surfactant, and we have that VQ mismatch. So our key finding in that that injury or exudative phase is going to be unresponsive to increasing O2 concentration. So reason being, if you have all of this fluid in the lungs, you can see this on a chest x-ray, you can see those patchy white infiltrates, and you have decreased lung area to work with from the atelectasis, no matter how much oxygen you give that patient, there's not enough airspace in there for that gas exchange to be taking place. Okay, another thing that we want to look for is your patient's hemoglobin and hematocrit, that oxygen carrying capacity, because then that's also going to affect how well they're able to oxygenate. Lungs become less compliant. There's no fibrosis happening at this point. It just means that with those alveoli closing, that you just have, again, it's harder to get those alveoli to open, which will decrease that compliance. And then the higher airway pressures must be generated. So your patient will be trying, be more like short of breath, trying to catch their breath. We put, a non-rebreather on them and 100%, and maybe their O2 saturation isn't increasing. They have like frothy sputum going on. Those are all indicative of that ARDS kind of cascade starting. Does that make sense? So higher airway pressures, if you're trying to take a deep breath, like that's a lot of work. That's a lot of increased work of breathing. So that's when we start thinking mechanical ventilation, because then we can control the pressure on the ventilator and, have that patient sedated and rested while the ventilator is generating those higher airway pressures. Okay, so reparative or proliferative, they're opposite. So we have the reparative phase where, maybe they're on the ventilator for a bit, the lungs start becoming more compliant, the fluid is reabsorbed, we start seeing clearing of the chest x-ray. Basically their ARDS is resolving, okay? That would be ideal, right? For some patients, we have the proliferative where, I've seen this in the ICU recently with some COVID patients that have gone into ARDS, where they've gone and they're starting to go into like the proliferative phase. And again, this timeline is not, concrete, but just kind of a general 1 to 2 weeks after that initial insult. If your patient does go into the proliferative phase, again, we have more of that inflammation. So more of that fluid with all of those mediators coming in. Fibroblasts, meaning that the lung remodeling of that tissue, the lung tissue starts becoming less compliant, more fibrous. Yeah, basically what that says. So fibrotic or chronic late phase or latent phase. Now you have dense, thick tissue in the lungs where there is not enough airspace left, if the patient is not on a ventilator, that they would be able to breathe regularly and still meet the body's demands for oxygen. Okay. And then think about it too, if they also have any like comorbid perfusion issues, even less likely to be able to meet the body's demands for oxygen and blood flow. So hypoxemia would continue. However, if they are on a ventilator, chances are at that point, what do you think we would have to do for them? They were intubated and on a ventilator. Could we successfully extubate them? Get them off the ventilator? No. So then we would be talking about, tracheostomy placement, tracheostomy and PEG tube placement with long-term mechanical ventilation. Okay. All right. So the manifestations, I don't want you to focus too much on those in terms of like your patient, because they are, oh, sorry, I had somebody joining in. Because they do kind of overlap. you know, and depending on how quickly a patient progresses with ARDS, you know, they might be having some later signs and symptoms, especially if they have like a comorbid condition like a COPD or emphysema. They might be demonstrating some cyanosis, which is typically a later sign. They might be demonstrating that earlier on. But just kind of a general idea of what your patient's going to look like, you know, has a diagnosis of ARDS, the hypoxemia despite increased FiO2. ABGs are going to start showing that progressive decline in the PaO2. One characteristic finding, you can see the whiteout lung where we have all of that fluid. It's not isolated to one area. So when we think about that, you know, typically if there's like a pneumonia or an empyema, which would be like an infection in the lung, it's usually isolated to one area. So your patient might be short of breath, but they really should be responding to O2 since there's other areas that, you know, where there's perfusion going on in the lungs. Here we see like a drastic decline in the amount of actual airspace that we can participate in that, that BQ exchange. Okay, so volutrauma, barotrauma, those kind of tie over back into mechanical ventilation. We talked about what are a couple settings that would help with that on your ventilator. What do you think?
Pressure control.
Pressure control. So having that, you know, high pressure limit, not using, you know, volume ventilation, but doing it more based on the, you know, the patient's resistance factors. And then also that PEEP, keeping that PEEP elevated to keep those alveoli open. Because again, as we mentioned before, the higher airway pressures must be generated and maintained to prevent that atelectasis. Okay. So renal failure, we know if it's not even, if there's decreased renal perfusion, but if there's decreased oxygen as well, stimulate that RAS system. Stress ulcers. So this again ties in with mechanical ventilation, decreased blood flow to the gut. You have that acid. So we always would use like a, you know, vast majority of patients are on some type of PPI to prevent that from happening. Okay, so our best position is going to be prone. Here we have, this is an old school prone bed. Here's our newer one, the roto-prone bed. Have you guys seen this in the ICU? No, there was a few of that. I think there was like 3 or 4 of them when I was there a couple weeks ago. Continuous lateral rotation therapy. So this is kind of continuously rotating that patient from side to side, preventing that fluid from staying in one spot. Moving on to, okay, so all of this is kind of a, well, this is kind of a, end of that is more of a review from your mechanical ventilation. Now for your favorite.
Okay, so
Let's see. This is like a crash course. How are you guys feeling about ABGs? Good?
Pretty good.
Yeah.
Cool, but
Good on that worksheet. That 15 questions on this worksheet, those were some tough ones. So if you were able to, you know, get through the 15 of those and get those right, you're in good shape. if I've graded all of them, so if you see like the ones you got wrong, just make sure that you're looking back to see, okay, why was it this answer as opposed to, what I had selected.
Amy, I submitted mine last night, like kind of late. Were you able to get to mine as well? 'Cause I wanted to screen it.
Nope, probably have not gotten to yours. I'm gonna grade it 3 minutes before the exam. Is that good? Does that work
That
for you?
would be tremendous. That would help so much. Thanks.
Yeah, no, I'll definitely do that. I'll definitely do that today. So we talked about our tracheostomy versus our ET tube. So tracheostomy, what type of suctioning do we do for that?
Open.
Open. Yep, sterile open suction technique. And then ET tube, what do we do for suction for that?
Closed.
Closed. See, this is so easy. I don't know why you guys are like stressing out about the critical care content. Okay, so you guys comfortable with what we do to check to make sure the patient has been intubated correctly? Yeah, your signs that we're looking for: symmetrical chest rise and fall, lung sounds, bilateral.
So if that last question says, what if the tube becomes dislodged? Are they talking about like the whole ET tube like coming out?
Yeah, so we would call for help. There is an obturator typically at the bedside for like reinsertion. Am I thinking of trach? My brain just froze. There's ambu bag like right at the bedside. Anytime a patient is mechanically ventilated, it's usually hooked onto the ventilator. So you would just have to ambu bag at 100% until they could come reinsert the tube.
Okay, that's what I thought. Would you need to do any like chin tilt, head lift? I don't think so.
Yeah,
right?
just your CE kind of, yeah, you're just ambu bagging because your patient would be sedated typically if they're on the ventilator anyway, unless they were in a comatose state, which either situation you'd have to open up their airway. Ambu bag, you would not attempt to reinsert the tube. Take it from me, every day, every time on skills day, every year, we'd have to go down and do skills day, and we would have to intubate. I don't even know why. Like we weren't trained, but I would always break the mannequin's teeth. Never failed. They had teeth that like clicked if you broke them, and I would just go to it and they would just be like click, 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 and I'm like, you now have no teeth. I will not be intubating anybody ever. So maintaining tube patency. So, we're not going to routinely suction. We talked about all the complications of doing that. Looking for those signs and symptoms that the patient needs suctioning. What alarm would go off on your ventilator if they needed suctioning?
High.
High. See, it's so easy. Open, closed, high. This is like, right? Kind of easy. No. So. It's not easy for me? Maternity. Oh, no, I'm kidding. You guys will be fine. Too soon? Talked about the different sectioning. At least you're not ending with, I think ortho. Oh, ortho. Anyone want to go into ortho?
I feel like ending with this would have been the best, and we wouldn't have had you as an instructor because you're going to be on maternity leave, right?
Yep. Yeah.
Yeah, so forget that then.
A little over 38 weeks.
You're at 38 weeks right now?
Yep.
Oh my gosh.
Yeah, I know.
You are ready to go. Holy
yeah,
cow.
My doctor the other day was like, we're going to talk about like an exit plan. I'm like, all right. I'm like, I'm doing okay though. Virtual, teaching virtual.
How are you not short of breath? I feel like I'd be losing my breath constantly.
If I was in class, I would be. If I was like walking around in class, I would be for sure. Just a lot of Walmart pickups, I guess. Not taking those long trips out. It's my feet that bother me the most. They have you guys ever seen like the Polish sausage that's like hooked to each other? Like at like the deli, like that are like stuffed. I feel like that's what my feet look like. Just like a couple of like stuffed sausages. Like I just have to keep telling myself like this is just temporary. Just have some extra fluid. It'll go away, and you'll be back on that red carpet at the Victoria's Secret show in a few months. So I just keep telling myself. So complications, so hypoxemia, if we forget to push that button for 100% O2. Bronchospasm really can't do anything about. We just got to make sure that we have the kind of like that steady, slow insertion of that catheter, making sure that we're not applying pressure on the way in, only, you know, applying that button intermittently when we're withdrawing the catheter. Same thing with mucosal damage, really can't do too much about that. What would help is, like, you guys know, if you have like a very dry airway, and you know, and you cough, like more at risk for, you know, damage to the tissue. So your mucolytics, like your acetylcysteine, your steroids that are going to help with inflammation and bronchospasms, like methylprednisolone or hydrocortisone. Those are going to help prevent that. And then adequate humidification, which is done through the ventilator anyway. So that also kind of prevents that mucosal damage. We talked about our mouth care. Talked about our strategies. So IV fluids, you know, repositioning the patient, that would help with thick secretions. Had some patients have the scopolamine patch ordered. It goes behind the ear, and that also helps, you know, decrease the amount of secretions.
I had a question about the suctioning. When you're not suctioning like 2 hours or on any regular basis if they don't need it, correct? You're suctioning as needed.
Yep, only as needed. And sometimes with respiratory therapy, if they go in and they're doing their assessment of like the ventilator, they'll, you know, do a quick little suction too, and then they'll come out and tell nursing staff like, hey, you know, I suctioned so-and-so. And that also kind of gives you an indication, okay, like they've just been suctioned. So, you know, I'll keep monitoring to see if they need it, but they should be good. Yeah, for a while.
The main reason for that is just for like injury to the trachea. You want to reduce the amount of like times you're jamming the Yankauer in, or
that tubing that's with
the closed tubing, right?
Yeah, I'm gonna back up to the picture.
I just want to know like the main reason why we're only doing it as needed, I guess.
Well, if your patient they're standing okay, you know, their vital signs. So here's the actual catheter with like enclosed in that sheath. So that's getting threaded in through the ET tube down and through the trachea and suctioning it out. So if they don't have, a lot of times what we see more is that it's not the actual ET tube that needs to be suctioned, it's the patient's mouth. So, you know, we can we'd have a Yankauer that comes, you know, in those little kits that they have for patients that are on a ventilator, those oral care kits. And oftentimes we can just kind of suction out the mouth and the back of the throat, and that'll get the job done. But to actually, you know, physically go through and suction out the trachea, it just depends on the patient and like their status, you know, with secretions, because doing it too often, like as you had just said, might have the reverse effect and cause more secretions.
Oh, that's right.
So, yeah, only as like an as needed basis. What I find is more common is the oropharyngeal secretions. So our high-low evac tube, this subglottal tube, will help with that, since that kind of sits in the back of the throat. But then we also can use the Yankauer to kind of, you know, work our way around the ET tube and the bite block to suction out the mouth. Okay, so I know we talked about the modes. So volume ventilation, so this, you know, more common. Gonna give that patient that predetermined tidal volume. With each breath that the ventilator delivers, it's going to give them that full tidal volume. So think if you're taking a deep breath, like, and you just keep taking the same depth of breath. Every breath that we take is a different depth, right? With a mechanical ventilator, it's giving that full tidal volume with each inspiration. The difference between that and pressure is that your tidal volume with pressure ventilation is going to vary with each breath. It's going to be based on what the resistance factors are when the ventilator goes to give that breath. So it has the tidal volume. It doesn't have a set tidal volume, but it has the amount of air that it's going. Oh, it hits that pressure. Any additional tidal volume will spill over into the environment once it hits that peak inspiratory pressure that's set. So this is going to be more common for patients that have your ARDS conditions, because we want to make sure that we're not going to be giving them too much tidal volume, or if they're going into that proliferative phase and they're losing more lung tissue and we have it set for tidal volume, maybe what was working for them then now isn't, and then they're at risk for volume trauma. So we want to make sure we do that based on pressure. Okay, your FiO2. So it's probably the simplest setting on your ventilator. It's just 100% when they're first intubated and then titrated down based on ABGs. ABGs should be taken within 30 minutes to an hour after being put on the ventilator, just to kind of see where we're at. And then after that, it's just kind of monitoring to see what their SpO2 and PaO2 are doing with the FiO2. The goal is to wean them off that FiO2. So the goal is, if they're doing good, they're satting 100% on the monitor, their ABGs start looking better, we can titrate down that FiO2. Rate is just breaths per minute the ventilator is giving, and then our PEEP is that positive end expiratory pressure, that little bit of pressure that's left in the lungs. Inspiratory to expiratory ratio, so 1 to 2 is common, meaning that, giving them for every 1 second of breath in, it allows 2 seconds for exhalation. This helps with the ventilation. And then for even just for like oxygenation and ventilation, the reason why your ABGs look good are the best, indicator of that is because your PaO2 is going to be part of your oxygenation, and then your PCO2 is going to be part of your ventilation. There's really no other way to determine how much CO2 a patient has without doing those ABGs. And if a patient is hyperventilating and they have the deep, shallow, or deep rapid breaths, and they're not having enough CO2, their manifestations of that might be like, dizziness, a headache. They might feel like numbness in their face and tingling. But we still don't really know that ratio until we get an ABGs from that. Sensitivity, you guys remember what that is for?
It's the effort generated to take a breath. It helps with people who have a weak effort.
Yeah, perfect. So the effort needed to take a breath. So with the sensitivity, that increasing that on the ventilator would mean that any additional effort that the patient makes, depending on what mode they're on, if they're on the ACV mode or CMV mode, ACV, CMV are the same thing, that little extra effort, the machine will pick up on that. So if you have patients that are cachectic or have that muscle wasting of the chest, that'll help the ventilator know that they have a weak effort, but I can sense that they're trying to take a breath, and I'm going to give them the full tidal volume. It prevents them from riding the ventilator at whatever predetermined rate, maybe at 12 breaths per minute. Maybe they're able to do 4 on their own. So assist control, they can breathe faster, they can breathe over the vent, but that rate is that rate. And every, at that frequency, every time that they get that breath, they're getting that full tidal volume with that breath. Okay, CMV. So same thing, the preset tidal volume is going to be set at that frequency. They're going to get that, but each additional breath the patient takes, they're on their own. So they're not receiving support from the ventilator. This would be for your patients that, are able to share in the work of breathing. Just got to make sure that we avoid hypoventilation by having a patient that is maybe sicker and, they're on CMV and they're not able to take their own spontaneous breaths, or they're not able to take enough, or they're taking them, but they're very shallow. And we also have to make sure that we avoid over sedating, over medicating patients that are in SIMBI, because they do need to be able to take those additional breaths on their own as well. Pressure support. So this is, going to be used for more of your weaning mode. With this, it's just giving that rapid inflow of gas with each breath, just kind of support keeping that pressure in the lungs. You've got your guys' case study that I will give you feedback on too once I have those in. So CPAP versus BiPAP. So what's the main difference between CPAP and BiPAP?
BiPAP has two different modes, and CPAP is just the one, right?
Yep, BiPAP has those 2 levels of pressure. It relaxes on expiration, whereas CPAP is just continuous airway pressure blowing in. It's kind of similar to your like pressure ventilation, but it's not usually high. It mimics PEEP, so it usually kind of keeps it at like that 5, that physiologic PEEP. So our alarms, our high pressure limit, we talked about, secretions causing that, kinked or compressed tubing might cause that. And then our low pressure limit is going to be more common with any type of leaks in the tubing or disconnection at the ET tube site. That can cause your low pressure limit. All right, you guys want to do the Kahoot?
Yeah.
Yeah. You could put in, you don't have to put in your name. You can just put in like and I'll post it as a challenge. I'll open it up without the timer so that you can do it again. No nickname for you, Leslie, right? You were just like in it to win it. I like that confidence.
I'm an open book.
Me too. I had a student before. Her name was Susie, and she was just like a phenomenal student. And so we had a joke where the other students, they all put in variations of her name for Kahoot. So we put like Susie, Dr. Susie, Susalicious, Susie, what was the one? But then I made the password for our next exam, Suze it or lose it. Good times.
That is awesome.
Miss being in class. All right, I think that's everybody, right? Good. Everybody wants to play? You can still play. Oh, there we go. All right, why did we auscultate first?
We try to see the reason for it. See
We
what's-
always assess before we intervene. All right, what type of rinse?
Chlorhexidine.
Chlorhexidine. Okay, if they're intubated and on a mechanical ventilator, what type of suctioning are we doing?
Closed.
And what's a risk factor of suctioning?
Increased ICP.
Increased ICP. Good job. All right, I gotta know. Who picked false?
I did.
Are they in anything? Let's go through. pH normal or abnormal?
The pH is normal and the CO2 is sort of normal, slightly acidic. And the PO2 is normal. HCO3 is normal.
Yep. Everything's normal. So they're heading more towards alkalosis with the decreased CO2, but 35 to 45 are our parameters. So you guys are too smart in fourth semester. You're like, they gotta be sick. I mean, if you're not sick, I'm gonna make you sick. Just pick one right answer for this one. All right, good job. It's Leslie against Leslie. All right, which one is more at risk for hypoventilation?
SIMV.
SIMV. And remember with hyperventilation, it's inversely related. So hyperventilation, you're breathing out too much CO2. So you'd be hypocapnic. With hypoventilation, you'd be hypercapnic. All right, good job. This one's a little bit more critical thinking. So stage 3 COPD, we expect their CO2 to be slightly elevated as their baseline. But what we worry about is if they're heading towards an acidic state, we want to make sure those kidneys are going to be able to reabsorb that bicarb. And with that creatinine elevated at 2.2, chances are probably not going to be able to do that. All right, how else is BiPAP used?
The word invasive until now.
Invasive or non-invasive? See, I had students say before, how come there's no true or false on the exams? You guys are probably happy now there's no true or false on the exams, right? True or false can be tricky. All right, great job. Yep, our low pressure alarm. Everything else, well, here we'd want to assess for suctioning if they need it, increase secretion, and that would be your high pressure alarm. Don't want to increase the IV sedation per unit protocol unless again, if your question is telling you that the patient appears agitated, tachypnic, hypertensive, the high pressure alarm could be going off if they're fighting the ventilator, breathing against it. But again, we don't have any of that information in the question. We want to assess for that. And then empty out the constant water in the circuit tubing. That would be a high pressure alarm too, because that water that sits in that tubing, usually respiratory therapy does it, but nurses will do it too. That can kind of cause the false high pressure alarm on your ventilator as well. Winner gets to graduate early. Just kidding. Wouldn't that be nice though? It's too bad that we're not in class. I had all these prizes for you guys. I had like packs of gum, because you guys are in nursing school, so like you don't brush your teeth. And like face wash, little combs, hand sanitizer, all these prizes. I can mail them to you. I'll send them via carrier pigeon. So any final questions? I've got a student meeting at 10. So I did kind of want to like go and eat. Rob, what'd you eat?
I had 2 pieces of sourdough toast with a little bit of mayo and shredded cheese, 2 pieces of sausage, maple sausage, and 2 eggs with hot sauce. That's what I have pretty much every morning.
Sounds good. So talk about a C-section, and then you got to talk about sausages now too. I really
Oh,
feel like you are. I feel
And
personal.
over easy eggs too.
So tomorrow I'll be on again for an hour. And if you guys have any lingering questions, yeah, I'll be there. Just kind of similar situation. I'll post the Kahoot link so you guys can play that and kind of turn the timer off. So you can kind of look through that and have a little bit more time. Is there anything else I can do for you? Anything that you need?
I'm working tomorrow, so where are you posting the recorded videos at? Is there going to be like a notification on?
Yeah, I'll post them right to the D2L announcements. You guys were able to access the class recording, right? From last class, the YouTube video. It won't let me post the actual link because it's like too much data or whatever. So I have to convert it to a YouTube video and then post like the YouTube link on there. But I'll post it on there. And I'll grade all assignments and have the case studies and stuff back to you by then too. Okay. All right. Well, thanks for coming. I thought I was going to be by myself. I really did. When I saw Noah come on, I was like, oh, it's just going to be me and Noah. But thanks for taking the time out of your schedule. All right. I'll talk to you guys
Thank you
soon.
so much.
All right. Bye.
Thank you.
Thank you.
Thank you.